a pleasure to everyone to have Professor Gamal and his generous education sessions, and from his time and his work. And he was going to talk today about cases of surgical critical care. As you know, surgical critical care and all critical care, every surgical patient will have some sort of a problem at the stage. They're not coming to you with all the surgical problem. They're going to be diabetics, or going to be ketoacidosis, going to be MI, status asthmaticus, reactions, sepsis, and all this you need to deal with it as a surgeon. It's part of your training, and we'll start the Professor Gamal to start the lecture.
Okay. Assalamu alaikum, everybody. We'll start. So I thought about how we can do this like a series of multiple series, actually, because I have a lot of questions. Some of them are straightforward questions, like asking you direct questioning. The other one is a case scenario question. Now, I really wanna say a couple of things, guys. That is the written exam here, and I'm sure Mu'min will recognize that. The written exam here in the United States, two format of questions. Direct question, what's the cause of this, and that? And the other one is a scenario-based question, which is also good, but both of them show up. So today you're gonna see a mix of these two together. And I think we'll talk to Muhammad for sure. And if you guys like this, I think we can have a series of questions about this specialty of surgical critical care and trauma. And I have questions, the same pattern of questions that you see here. I have, we can make a series, you know, a gastrointestinal series, or a colorectal series, and things like that, of question-based, which I think is the best way to learn these days. Even our medical schools here, the vast majority of medical schools, including the big one, Harvard and all this, they really stopped to the lecture format of teaching. Everything is a small group like ours here, and it's question-based interactive discussion. Okay, so let's try and see how that works. Okay, the syndrome of inappropriate antidiuretic hormone secretion is characterized by, and anyone here can answer, please. And again, I'll talk to Muhammad. Please, guys, this is interactive. We are here to make mistakes so we can all learn. So please speak up and, you know, tell me what you think. The syndrome of inappropriate antidiuretic hormone secretion is characterized. It's one answer here. By the way, that's not a British system of true and false. That's not that. This is one single answer, and there is no double negatives. There's no except. There's no all of above. The American Board of Surgery instructed question writers not to have any of these formats of except, or double negative, or all of the above, or none of the above. You won't see any of that. So one single answer is correct here, guys. Go ahead, anybody, please. Is it hypovolemia, increased urine sodium concentration, or hypernatremia, or plasma hyperosmolarity, or excessive diuresis?
Hello, Prof.
Yes, Asim. Assalamu alaikum.
Yes,
go ahead.
Alaikum salam. I will answer this by increased urine sodium concentration.
Excellent. That's the right answer. So here is the thing, Asim. We will notice in these questions, even the wrong answers are relevant statements, relevant sentences, so we can discuss and see why they're wrong. We're not just gonna go over the questions and that's it. That's the right answer, next question. No, we need to have a discussion. Why we chose this, what's the rationale, basically to have a critique, educational critique with each question. So can you explain to us why B is the answer? What's the rationale here? Go ahead, Asim. Asim, can you hear me?
Hello, boss.
Yeah, go ahead. Why is it B? Why is
Yes,
B the
because
answer?
ADH hormone will increase the aquaporins that will retain fluid, which is water, pure water. This will increase the volume, will make hyponatremia, and for that it will decrease the increase the concentration of sodium by decreasing the water output in the urine.
Right, that's absolutely correct. Let me ask you a couple of questions. What's the main stimulating secretion for antidiuretic hormone? What's the main regulator for antidiuretic hormone secretion? The main regulator.
Hypothalamus, I think, ADH releasing hormone.
Yeah, but what stimulates the release of ADH under normal circumstances? What's the main regulator? Sorry?
It's increased when the body needs water.
Yeah.
Mostly because of hyponatremia or no?
No. What is the main stimulus?
Hypernatremia, most likely, I think.
Hyperosmolarity, correct?
Yes.
Hyperosmolarity. The main stimulus for ADH secretion under normal circumstances, which is vasopressin, which is secreted by the posterior pituitary on the hypothalamic stimulation, is hyperosmolarity. The syndrome of antidiuretic hormone is SIADH, inappropriate antidiuretic hormone secretion. Asim, why is it called inappropriate? Why is it not appropriate? Why is it inappropriate? Why do we call this inappropriate?
Because body does not want this water, I think, just.
Because it's a secretion of antidiuretic hormone in the absence of hyperosmolarity. You with me?
Yes, boss.
The main stimulus of ADH secretion under normal physiologic condition is hyperosmolarity. If you do not have hyperosmolarity, there is no need for ADH to be secreted. If ADH is secreted against the fact that the patient is hypoosmolar, then we call that inappropriate because it shouldn't be there, right? And that will result, the action of antidiuretic hormone, what is the site of action of antidiuretic hormone? Where does it work?
Kidney.
Where? Which part of the kidney?
I think distal convoluted tubules.
No, it's collecting tubules. And it opens the pores in the collecting tubules to absorb water. And therefore, water is absorbed, sodium is not absorbed with the water, therefore the urine is hyperosmolar and has high sodium concentration. That's for B is correct. On the other hand, at the same time, the plasma is hypoosmolar and hypervolemic because there's a lot of water being absorbed, and hyponatremic because there's a lot of water being absorbed and sodium concentration is the same. That's why C is incorrect. And plasma hyperosmolarity, D is incorrect because it's inappropriate. This water is diluting the plasma. And instead of excessive diuresis, no, you're gonna have oliguria. You're gonna have less urine output. So the answer here is B. And just I want to remind you guys, This is the American style of questioning. It's not the British. There's no true or false. It's always one question, one answer is the correct answer. So syndrome of inappropriate antidiuretic hormone secretion, it's hypersecretion of ADH in the presence of or in the absence of hyperosmolarity, leading to the absorption of water, excessive water causing hyponatremia and hypervolemia and increased urine concentration and oliguria. And ask him, when do you see that in a surgical patient? Remember we said it's a surgical critical care. When do you, it's not just a physiology lecture or a physiology test. When do you see that in a surgical patient?
It comes with trauma patients, with especially for the head and chest.
Well, yeah, I mean, head injury. Head injury patients on the surgical critical care are subject to SIADH. They are actually, and we'll come in part 2 in the future next week or the following week when we have part 2 of surgical critical care. And I'd like to combine this as a surgical critical care and trauma critical care as well, you know, taking care of trauma patients in ICU. They are a head injured patient, traumatic brain injury, TBI, also are subject to 2 hormonal endocrine disturbances related to head injury. One is SIADH, and the other one is what, Asim? You see in traumatic brain injury as well? What's the other one?
Sorry, I didn't hear the question.
What are the endocrine abnormality commonly seen in patients with traumatic brain injury on a surgical intensive care unit? 2 endocrine abnormalities related to ADH. What are they? SIADH is one of them. What's the other one?
Hypernatremia, I don't know.
Anyone, guys, who's listening to us, a traumatic brain injury, head injured patient on a surgical ICU, they are likely or commonly having 2 phenomenon, 2 endocrine problems related to ADH secretions. One of them is SIADH, this one. What's the other one?
Diabetes insipidus?
DI, absolutely, diabetes insipidus. And we'll come to that later when the question comes. That's good. Next question. Normal A9 gap metabolic acidosis is associated with which one of the following? And maybe for Fatima, can you help us with this? Or Asim, you can help us if Fatima cannot hear us.
I will answer by D, severe diarrhea was.
Excellent, good for you. This is perfect. Can you tell us why? Tell us the story. Let me ask you, what is A9 gap metabolic acidosis?
And
What's the A9 gap, Asim? Can you tell me what the A9 gap is?
It's calculated from formula using sodium, potassium, and bicarbonate, I think. The normal, it will be between 10 and 12.
How do you calculate A9 gap? What's in the equation? Without numbers, we don't want numbers. We just want to know what's in the equation of calculation of A9 gap.
Protons like sodium and potassium, I think, plus the minus the bicarb.
And that's it?
And chloride, I don't remember.
Yeah, yes, that's correct. A9 gap is calculated. Sometimes a lot of people would ignore potassium. You can ignore potassium. A-line gap is calculated. It's a normal thing that we have in our body, and it's calculated by adding, or the equation. The equation is sodium should equal, sodium in my body should equal chloride plus bicarb. This is the equation. Sodium should equal chloride and bicarb. Stay with me now. So if my sodium concentration, Asim, is 135 milliequivalent, me, normal. My chloride, let's say the chloride is 100. And the bicarb is, let's say, 25. So you have 135 on one side and 125 on the other side. This could not be normal, Asim, in the human body. In the human body could not be normal because the positive is 135 and the negative, chloride and bicarb, is 125. There is 10 difference of charges, of positive charges in the body. This is not how our physiology works, because my hand and my body cannot be positively or negatively charged. It has to be neutral. If I was charged, I would grab that pen. I would never be able to let go on it because my hand is charged. And that's not the case. The positive charges in our body should equal negative charges. So how come my sodium is 135, which is plus cation, and A9, which is chloride and bicarb, are 125? There is 10 difference. Asim, why is that? What is that 10 difference in my physiology?
Might be because of presence of another acid. Another negative charge it should be.
Correct, you're absolutely right. There is 10 negative charges that are there, that are missing, that I'm not seeing in this equation. What are they? What are these 10 negative charges? They have to be there because my body should have equal positive and negative. What are the 10 negative charges that I'm not seeing in this equation? They should be added to the sodium, to the chloride and the bicarb. What are they in our body?
Can be the acids, both the lactic acid, the ketones.
No, we shouldn't have lactic acid normally in our body.
Okay, the proteins.
Proteins, which one that we all have, the most important?
Albumin.
Albumin. So the biggest contributor to the negative charge in all our bodies, the normal A9 gap that we have, the biggest contributor to that is albumin, and other things like phosphate and things like that. So some proteins and phosphate and all. That's all normal. That's all normal. So this is rule number one, guys, for us to understand what it means to have a A9 gap metabolic acidosis versus non-A9 gap or high A9 gap metabolic acidosis. Stay with me, guys, for a second, because this is really important for us to understand. And every single exam we have here for our residents and trainees has this every year. So my normal A9 gap is 10 to 12, all of us. Fact number one, every single one of us physiologically has a normal A9 gap. It's about 10 to 12 milliequivalent or negative charges. It's mostly related to the concentration of albumin, phosphate, and other proteins that we have in our body. That's normal physiology. The reason we call it gap is we don't see it on our famous equation of sodium on one side plus chloride and bicarb equals chloride and bicarb on the other side. So we call it gap because I don't see it. That's rule number one. Rule number two that we all should know, that chloride and bicarb, just let's have an agreement. Our bodies cannot be charged. They have to be neutral. Chloride and bicarb in any normal physiology in our body go in opposite directions. If chloride goes up, bicarb will go down. If bicarb goes up, chloride will go down. If bicarb goes down, chloride will go up. Just to remember that. If bicarb will go down, chloride will go up. It has to happen that way to keep neutrality. So always the case. Good. So with these two facts, we are going to see what it is that metabolic acidosis can be either A9 gap or non-A9 gap. And the simple way I tell that to all our trainees is this. Look at the metabolic acidosis, causes of metabolic acidosis, and think. If the cause of this metabolic, if the acid that's being added to the body to cause this metabolic acidosis, if it's not seen on this equation, sodium, chloride, bicarb, three things. If what you see that is the cause of metabolic acidosis has nothing to do with these three things, it's high A9 gap metabolic acidosis. Again, you have a metabolic acidosis, think of the causes that you have. Look at the causes. If the cause of metabolic acidosis is not any of the three elements that you see on the A9 gap equation, sodium, chloride, and bicarb, if the cause is not in this equation, your metabolic acidosis should be a high gap. High gap. So, however, if the cause of metabolic acidosis is one of these three that you see in the equation, it will be normal A9 gap metabolic acidosis. Example, if I give somebody acid like chloride, if I give somebody lots of chloride, can somebody tell me when do we give people lots of chloride? It's not a trick question. We do it every day, especially in the medical ICU, not much in the surgical ICU. When do we give people a lot of chloride intravenously? What do we use to give them that?
KCl?
Sorry?
KCl?
N, right?
Potassium chloride.
Yeah, but we don't give them potassium chloride that much. Otherwise, it's a lethal injection. You know that we don't do that. When do we give people lots of chloride? Lots. All day. Exactly. Normal saline. NCL, NaCl, normal saline. If you give people for 2 or 3 days excessive resuscitation with normal saline, you are giving them an acidifying solution, having a lot of chloride. You will have normal A9 gap metabolic acidosis. You're giving them a lot of chloride and you're going to have a normal A9 gap metabolic acidosis. That's one example. Usually don't give people HCl, right? We don't give them that, right? And KCl will just give them 1 amp or something, but usually our medical colleagues, especially in medical ICU, not much in surgical ICU because we use lactated ringer mostly. There is a condition that we're gonna get in part 2 or 3 next week, whenever, for our next series, called excessive normal saline resuscitation in trauma and surgical patient. If you are using normal saline excessively for volume resuscitation, you will have excessive chloride and you will have metabolic acidosis, and this metabolic acidosis will be a normal A9 gap. Why? Because it's caused by chloride. Is chloride in the three elements, sodium, chloride, and bicarb? Did I see in the equation? Yes, it is. Then it's a normal A9 gap metabolic acidosis. That's gaining chloride. What if I'm losing bicarb? When do we lose bicarb? When does anyone lose bicarb? When does any patient lose bicarb? Anyone, guys? When do we lose bicarb? What condition?
In case of vomiting.
I don't think you lose bicarb in vomiting. You lose chloride in vomiting. You lose acid. When do you lose bicarb?
Diarrhea.
Diarrhea. Absolutely. 100%. Diarrhea. Diarrhea. Intracutaneous fistula. Bicarb, guys. Small intestinal secretion, enteric secretions, alkaline, lots of bicarb. If you lose, second question, bicarb. Is bicarb one of the three things, sodium, chloride, and bicarb in the equation? Yes, it is. So if you're losing bicarb, you get, what's going to happen to chloride? It's going to go up because bicarb is going down. You're going to have a metabolic acidosis. Is it high gap or normal gap? Of course, it's normal gap. Why? Because bicarb is in the equation. So, lactic acid. Adding lactic acid because of anaerobic metabolism, right? Will give you metabolic acidosis. Do we see lactic acid in the equation, guys? Do we see it?
No.
So it's going to be a high gap metabolic acidosis. Ketoacidosis, diabetic ketoacidosis. Do we see keto acids in the equation? No. In fact, our medical colleagues and those of us who are doing medical and surgical ICU combined, I do medical ICU too, often, at least twice a month. Not a pure medical, but combined medical and surgical ICU in one place. So you get a mix of patients, which is good for us as surgeons, you know. What do we do when we get a DKA? We measure the gap. And if we see a crazy gap, we're still in bad shape. We need to fix that. It's a parameter of improvement, ketoacidosis. Salicylate, we don't see salicylic acid in the equation. It's a high gap. Uremic acidosis, uremia, all these organic acids, we don't see them in the equation. So it's going to be a high gap. The only time in this, the only thing in this question that we can see in the equation is loss of bicarb because of diarrhea. Also, another reason in a surgical patient is high output intracutaneous fistula. That will also give you a high A9 gap metabolic acidosis. Good, good, guys. All right, case scenario. Who can take this from me? Asim or Wala or Malak? What do we think? Can you guys see it? Can you read it for us?
Forty years old construction worker is crushed by a concrete wall and sustains pelvic fracture and soft tissue injuries. His initial hemodynamic monitored rhythm strip is shown. V1, 2, 3. There is a tented T wave. The most appropriate next step is to give IV intravenous furosemide. No. Give 10 ml of 10% calcium gluconate solution IV. Yes. Give 50% dextrose with insulin IV. Yes. Maybe. Plan for emergent hemodialysis maybe give what?
K-exhalate enema.
Excellent enema.
Mhm.
Okay. First, to protect the heart, give the calcium.
So,
So I will give
what
B.
do you see? What do you see on the EKG?
I see tented wave, T wave.
Peaked
So-
T wave, right?
Yes, yes.
Peak T wave. Why do you think he has hypercalcemia here?
It's hyperkalemia.
Sorry, hyperkalemia. I'm sorry.
Yes.
Why do you think he has hyperkalemia here?
Most likely rhabdomyolysis.
Correct. Right. Soft tissue injury. Right. Massive
Yeah.
soft tissue injury. So, Asim, can you tell me the modalities or the ways of management of hyperkalemia in the surgical ICU? How do you treat hyperkalemia in the surgical ICU?
We should first protect the heart by giving calcium, gluconate 10% in 10 ml in 10 minutes, I think.
What is the indication for that? Do you give it to everybody with hyperkalemia?
This is to protect the heart from going into an arrest.
I understand. Is calcium gluconate or chloride indicated in all patients with hyperkalemia?
As far as I know, boss. Yes.
What do you think, guys? Anybody? Wala, Malak, Fatima, anyone? Is calcium chloride or calcium gluconate, are these indicated in all cases of hyperkalemia?
Hello, sir.
Yeah.
Hyperkalemia is different levels, the mild, the moderate, the severe ones. The severe ones, like in this case, I should give calcium to protect the heart.
Excellent.
But in some cases, like mild, I can give calcium resonium, for example, like mild or moderate. Maybe.
But how do you know that it's what's the single indication?
The ECG change.
Thank you. I hope everybody heard this, guys. This is excellent. If you have hyperkalemia associated with EKG abnormalities, this is the indication for calcium therapy. Calcium therapy, let me repeat this, calcium therapy in hyperkalemia is indicated if hyperkalemia is associated with EKG changes. So whenever you see somebody with hyperkalemia, the first thing we get is EKG tracing, right? So back to you, or you can stay with you, Iman, or we go to Malak, and we ask, the first thing is to protect the heart, correct? What other ways we treat hyperkalemia with?
After making sure that the heart is protected by giving the calcium, then I can go to the second step by shifting the potassium from extra to intracellular space.
Excellent.
Yes.
Excellent.
I have many ways.
You guys don't
do this.
need me. You already know everything. You guys don't need me. This is excellent. Right. Okay. Shifting the potassium to the cell. And what's the third step before we go into details? So we're mentioning there are 3 ways to treat hyperkalemia. 1, protecting the heart. 2, shifting potassium into the cell. What's number 3?
Maybe knowing the cause.
Potassium chelation.
No, getting rid of the potassium. Did you notice this, guys? The first 2
Hemodialysis.
did nothing to remove potassium from the body. Potassium is still there. Potassium is still there.
Hemodialysis is a cause.
Yeah, well, the third, no, well, there are other ways, but the third one is to remove potassium from the body. So, ICU, treatment of hyperkalemia. Number 1, protect the heart. Number 2, shift potassium into the cell. Hide it. Under the carpet, hide it. But it's still there, hasn't gone. Number 3, actually remove potassium from the body. Each step has its own methods of achieving so. How do you protect the heart? How do you stabilize the membranes? What do we use? Right there. Calcium, right?
Yes.
Calcium glucuride or calcium gluconate. Okay. How do we shift potassium into the body? And just remember, potassium is still into the body, still in the body, but it's shifted, it's hidden. It's like when you have, as I teach my residents here and I say, okay, your house is a mess, your parents are coming, you have a lot of cleaning to do, but you don't have time. What you do, you push things under the carpet, right? The dirt is still there. You haven't cleaned anything, but you hid it. So when somebody comes in, they're not gonna see it. So that's what you're doing with potassium. You're hiding it in the cell. How do you hide potassium in the cell? What do you use?
I have many ways actually for doing this. Either giving the patient dextrose with insulin, IV, 25 milligram dextrose with 10 units.
Just a second.
Yes.
Just a second.
Okay. Okay.
What actually shifts the potassium into the cell? Is it dextrose or insulin?
Insulin, but I need dextrose so that the insulin can work in.
Why do you need dextrose? You do need dextrose. When? When do you need dextrose?
At the level of receptors, insulin will shift the potassium intracellular, but without dextrose, you will not.
No, it will. It will. Trust me. Insulin will shift the potassium into the cell regardless. Regardless. Why are you giving dextrose?
For
To prevent hypoglycemia.
To prevent hypoglycemia. Therefore, you should add something to this statement. We are going to give regular insulin along with glucose unless the patient is
Diabetic.
already hyperglycemic, right? So the guy's glucose is 210 already, 220, and it's hyperkalemic. Why should I give him dextrose? I don't need dextrose. Let the insulin work, okay? And so what you need here, it's a common confusion with a lot of people. They think that you need both glucose and insulin to shift potassium into the cell. No, you don't. You need insulin. Why do you need insulin? Because insulin stimulates the ATPase pump. The ATPase, this receptor at the cell membrane, insulin stimulates that. And the action of ATPase pump is to flip sodium outside the body and get potassium inside the cell. That's what the ATPase does on the membrane. Sodium out, potassium inside. Insulin goes to that pump and stimulates it to do its job. However, if your blood glucose is 120, normal person, not diabetic, you're worried. If you give the insulin, you're going to cause hypoglycemia. So you give some dextrose with it. Otherwise, you don't need it. Good. So item number 1 for hiding the trash, the garbage under the carpet is, i.e., shifting potassium inside the cell, is to give insulin. Minus plus glucose. It depends if you need it. How else, Iman or anyone, we can shift potassium, hide it under the carpet, push it in the cell? How?
I can give the patient salbutamol inhaler if the patient can take this, if the patient is awake.
Of course he can. So nebulizer, beta agonist nebulizer, beta agonist nebulizer, correct, that you give for the asthma people. Why? Because catecholamines, the beta agonist receptors, also stimulates the ATPase pump. Good, excellent. A third method to push potassium into the cell. How? How do you push potassium in the cell, guys? A third method. Iman, anyone?
I will assume alkalization of blood.
Absolutely. Make them alkalotic. Think about this, guys. Think about this, right? Wherever there is alkali, potassium goes to the other side. Wherever there is alkalosis, there is always hypokalemia, right? So make them alkalotic. Make them alkalotic, potassium will shift in the cell, right? Now we need to get rid of that enemy, that potassium. Actually remove it from the body. Remove it. Can you give me 3 methods of removing potassium from the body?
Yes, sir. I can give him, first of all, diuretics.
Thank you. Lasix, number 1. Number 2?
Potassium resins.
K-exalate, absolutely. Excellent. Number 3?
With the sodium. And lastly, hemodialysis.
Perfect. Absolutely perfect, guys. We just covered totally the treatment of hyperkalemia in a surgical patient in a surgical ICU. And the methods are, number 1, protect the heart if hyperkalemia is associated with EKG abnormality. Number 2, hide potassium into the cell. And you can do that with 3 different ways. Number 1 is make the plasma alkalotic, or give them insulin, or give them beta agonist nebulizer. Number 3, effectively remove the potassium from the body. And this can be achieved by 3 other means. Lasix, or furosemide diuretics, or hemodialysis, which is the ultimate, most definitive way to remove potassium from the body, or K-exalate. K-exalate is, it takes time, takes 2 or 3 days. So obviously the other methods are faster and required quicker. On our test, the written boards, the American Board of Surgery, the in-service exam, oral exam, everything, there is always hyperkalemia. Always hyperkalemia. Let alone, of course, the American Board of Surgical Critical Care, right? It's good, guys, excellent.
I just have a question regarding potassium bicarb. Hello, sir?
Yeah, you mean sodium bicarb?
Yeah, it's a sodium bicarb, yes, I'm sorry. I know that sodium bicarb is alkali, but at the end, it's going to induce intracellular acidemia. So how can I guard against this? Or should be given by cautious? How much the dose to be given or to prevent intracellular acidemia at the end of his action?
I don't know, because of the CO2 you mean in it?
I'm not sure about the mechanism, but as far as I know, the sodium bicarb at the end, yes, it's an alkali, but it will induce intracellular acidemia. And that's why people give it with cautious. So how much dose should I give?
No, we usually just give 2 amps or something. I'm not really sure about the mechanism, to be honest with you, man. I don't.
Okay.
I'm not friendly with the mechanism, so. Okay. Right, next question. It's a little bit long. Anyone can take this, guys? Iman, anyone? Asim, Malak, anyone?
A 70, I'll go, boss.
Go ahead.
A 70-year-old man underwent ciliatomy and splenectomy for blunt splenic injury. He is admitted to ICU and remains intubated on norepinephrine infusion. He is hypotensive, tachycardic, and urine output of 5 ml per hour for the last 2 hours. The most likely underlying acid-base disorder will be metabolic alkalosis, respiratory acidosis, positive anion gap, metabolic acidosis, normal anion gap, metabolic acidosis.
Right, Asim, we just talked about that. Just think about it for a second. Let me ask you a question first. Do you think it's going to be alkalotic or acidotic?
Acidotic.
Who is this? Sorry.
Hello.
Yeah, hello. How are you?
Yeah, I'm good. He's going to be more acidotic.
What's your name? I don't have your name.
I'm called Romanus.
Romanus?
Yeah.
Okay, Romanus. He's going to be acidotic, correct?
Yes, please.
Good. So what kind of acidosis do you think? A respiratory or metabolic?
It's more metabolic because it's on inotropes and there will be a decreased perfusion. So anaerobic metabolism will be taking place, lactate will be produced.
Okay, so what's the answer?
Maybe D.
All right, so we all agree, guys? Absolutely, we just talked about that. He's accumulating lactic acid. And I don't see lactic acid in sodium chloride and bicarb equation. So it is a positive metabolic, positive A9 gap or high A9 gap metabolic acidosis. High A9, another word you can use instead of positive is high A9 gap metabolic acidosis. Right? Excellent, it's good, guys, it's good. Right. Next question, keep going. Anyone? Remus, maybe you can take that one too. All right, guys, can you hear me? Anyone?
I read it out again.
Go ahead. Go ahead.
A 70-year-old woman with end-stage renal disease is undergoing emergency repair of an incarcerated femoral hernia. She is having abnormal oozing throughout the operation. The most likely abnormal test will be prolonged PTT, increased fibrinolysis, elevated international normalized ratio INR, prolonged bleeding time, thrombocytopenia. She's having end-stage renal disease, so she will have a problem with platelet aggregation. She will be given also some heparins for the hemodialysis. And now she's bleeding intraoperatively. Most likely because of DIC, because of oozing throughout the operation. So I'll go with B.
Why would she have fibrinolysis?
Because of the DIC will decrease all the parameters, but
why does she have DIC? She's not that sick. She just came for elective operation.
okay.
So can we say it's E, thrombocytopenia?
Why would the platelet count be low?
Because this is a patient with end-stage renal disease. Probably he had gone through a lot of series of dialysis. And sometimes in dialysis, they get fragmentation of their platelets.
Do we agree, guys? On the American Board of Surgery, every year there is bleeding in uremic patients. What's the cause of that?
I will go with A, prolonged PTT. Due to she's end-stage renal disease on hemodialysis. So, and the dialysate contain heparin. So the heparin will prolong the PTT, activated partial thromboplastin time.
But she's not on dialysis this second, right? She had dialysis usually like a day before.
I guess, sir, the patient with end-stage renal disease, they have abnormal platelet or platelet dysfunction. So they have platelet, it's present in their body, but with dysfunction. So probably it's prolonged bleeding time.
Yes.
Excellent. Absolutely excellent. That's exactly the answer, guys. I have nothing else to add. Patients with uremia, uremia affects the platelets function. Typically, it causes depletion of von Willebrand factor, which is a cofactor for platelet aggregation. Von Willebrand factor, guys, is on the American Board of Surgery test annually. Every year, it shows up. Every year, this question shows up. Bleeding associated with uremia. Uremia impairs, decreases von Willebrand factor's activity. And the von Willebrand factor is a cofactor of platelet aggregation. So in order to fix this problem, you have two ways to fix abnormal bleeding if you're operating on a uremic patient. Number one is to stimulate von Willebrand factor secretion. And does anyone know how I can achieve this? How can I stimulate the secretion of von Willebrand factor from the epithelium, from the endothelium? Anyone? Because that's going to come in a question sometime. How can I stimulate the release, the secretion of von Willebrand factor from the vascular endothelium? What can I give the patient?
Vasopressin.
DDAVP, excellent. DDAVP, which is vasopressin analog.
Pressin, yes. Yes.
100%. They can take it even by nasal route or something like that. Excellent. Every year they ask you this question. Every year, right? So DDAVP. Now, what's the other way I can fix abnormal bleeding in uremic patients?
And give cryoprecipitate.
No, dialyze them. Let's
Okay.
get rid of the uremia. Let's get rid of the uremia with dialysis. And because the platelet count is normal, it's the platelet function, the aggregation is abnormal. And what's the best test in our hands so far to test the platelet function? It's bleeding time. It's excellent, guys. This is good, Iman. This is good. Next. That's a very long question. Right. Who's going to read that one for us? Anyone, guys?
A 60-year-old diabetic woman presents with necrotizing soft tissue infection of her thigh and lower abdomen. She underwent emergency soft tissue debridement and broad-spectrum antibiotics are initiated, along with aggressive fluid resuscitation. 12 hours later, she develops generalized oozing from all surgical sites that had been previously dry. Lab values shows elevated PTT ratio, D-dimer, and low fibrinogen. The most definitive next step should be transfuse FFP several units, giving IV desmopressin acetate, adding antifungal agent to the antibiotic regimen, returning to the operating room and further debridement, starting antifibrinolytic therapy. This is obviously a DIC.
Agree. So how we can fix DIC?
We will give fresh frozen plasma.
Okay.
Or
And
A.
that will fix it. So ask him, just read the last sentence in the question. What's it asking for?
Starting antifibrinolytic
No.
therapy.
No. The last sentence.
The most definitive next step should be.
The most definitive, right?
Yes.
Okay. Is FFP the most definitive? Let me ask you a question. Go ahead. Sorry.
Yeah, and this for among those options, maybe we're going with the B, because no antifungal will do any, no debridement. Antifibrinolytic therapy will increase the bleeding, so maybe B.
Is that definitive, Iman? Why did this lady got DIC? Why did she get DIC? Why did she get DIC, this lady? It's not a trick question, guys. Why did she get DIC?
She has necrotizing soft tissue infection.
Okay, perfect. Right? So how can we fix DIC then?
So by returning to the operating room?
100%. The most definitive way to correct DIC is to get rid of the cause. Return to the operating room. You have dead tissue that you haven't taken care of. And no matter what you can give her all the FFP in the world. You can give her all the DDAVP in the world. You can give her anything, antifibrinolytic, tranexamic acid. You can give her anything. She will never correct her DIC because you're chasing a ghost. She has dead tissue in the body that's driving this. It needs to come out, needs to be removed. And the question is very fair. It is asking you the most definitive. So in fact, if they put that question on our written board here, they would probably underline the word definitive, right? It's asking the most definitive way, okay? So return to the operating room. Soft tissue infection, guys. Let me just ask you a question and you can answer me. Do you see a lot of necrotizing soft tissue infection in Sudan? I suspect yes, right?
Yeah, very much there.
Absolutely, Iman. I suspected that also. We do here too. There's a lot of farm accidents. There's a lot of morbidly obese diabetic patients with injuries. There are a lot of construction workers, and that's any busy, active, acute care, surgical critical care center and all this will also always have soft tissue infection, necrotizing. And I suspect in Sudan is very common. Let me tell you one thing. The most essential aspect of the treatment of those people is to completely remove the necrotic infected tissue. As long as you have that in there, the pathophysiology will keep going and the driving force will never disappear. No matter what you do, antibiotics, whatever, you always have to make sure you have complete eradication of the necrotic infected tissue. You know what this is like? This is like having a catabolic element in the body, stool in the pelvis because of anastomotic leak after colectomy or something. And you are trying to fix the hyperglycemia and the sepsis and the septic response of this patient by giving antibiotics, by giving nutrition, and you're not successful. By taking them off the vent, you can't get them off the vent. You cannot prevent the hyperglycemia. You cannot prevent stop the hypotension. You cannot, all this septic response, you're unable to fix it. And you wonder why. The reason is you have the catabolic source still there, the leak, the pus, the stool. still there. Same here. You have to get rid of the infection focus. So the most definitive thing here is returning to the operating room. Okay, it's good, guys. Next, anyone will take this?
Okay, 65-year-old man is admitted to the ICU with serum sodium level of 165 and severely altered mental status. The most serious neurological consequences will be related to either cerebral hemorrhage, brain swelling, cerebral edema, increasing ICB, demyelination. So sodium is very high, 165, and sodium will affect the brain in a manner of I guess I'm going with C, cerebral edema, but it caused demyelination too. I'll think a lot.
I'll go with A.
Asim, you're absolutely right. Why? Why is the answer A?
Because the oncotic pressure is high, then the brain, the water will shift to the cell, to the intravascular. This will lead to decreased brain tissue size, which make it vulnerable for bleeding.
That's absolutely correct, guys. Let's just talk about this for a second because it's really important. And let's have some rules. It's always important to have some rules, guys, in education, rules and practice so you can go by. And when you have these rules in your mind, in your head, dealing with details will be easier. You know, just like we talked about potassium, you have 3 rules, you know, protect the heart, hide it, and get rid of it. So the rule here is number 1, sodium abnormalities are shown as neurologic problems, while potassium abnormalities are shown as cardiac problems. So always remember that. Sodium abnormalities are revealed as neurologic problems, usually brain, while potassium abnormalities are always cardiac issues. That's number 1. Rule number 1. Rule number 2 is the brain cell and the plasma. They have the membrane between them, the cell membrane in the brain cells, in the cerebral cells, right? Just to remember, normally they under, you know, in equilibrium, you know, they're going together just fine. Potassium 130, sodium 135, and brain cell is 135. That's normal circumstances. So that's rule number 1, sodium abnormalities show as neurologic disorder. Number 2, under normal circumstances, there is balance of sodium between the brain cells and the plasma, right? Okay. Rule number 3, with any abnormality of sodium in the plasma, serum sodium, the brain cells take their time, lag behind to adapt to the change into the plasma sodium. So if the plasma sodium all of a sudden becomes 165, right? The brain cell will not see the 165. They will not adjust. They will lag behind. And therefore, the brain cells will be living in a hyperosmolar environment. So water will be sucked out of them. So just remember that. Brain cells take time to adapt to the changes in the sodium. This is what happens here. You have a hyperosmolar situation. The brain, the blood-brain barrier takes time to adapt to this. The brain is still living in the days where sodium was 135. However, the serum is 165. So water is sucked out of the brain, right? And it's causing shrinking. Because of that shrinking, it increases the movement of the brain in the skull and all this. It makes contraction of the astrocytes and all that. It makes them prone to intracerebral hemorrhage. So hypernatremia, acute hypernatremia. If you see a pathology in the brain, it's usually intraparenchymal hemorrhage, cerebral hemorrhage. You do MRI on those people, or you do head CT, you will see intracerebral hemorrhage. So just to remember that the brain lags behind, because it's going to come later, not today, maybe in another session. Remember the story. What happens if you correct hypernatremia quickly? What happens to the brain? And we'll talk about that. So just to remember that. It's shrinkage of the brain because swimming in hyperosmolar is not adapting quickly, resulting in cerebral hemorrhage. It's good. Next, guys. We'll make that the last question, guys. Go ahead.
A patient with extensive burn of the trunk to endotracheally intubated, is endotracheally intubated. Arterial blood gas shows PCO2 65 and PO2 150. Peak airway pressure is 45 and chest X-ray is normal. The most appropriate management is insertion of bilateral chest tubes, chest wall excarectomy, infusion of neuromuscular blocking agent, bronchodilator inhalation, IV Lasix. Okay. This is a burn patient intubated with a trunk burn, so scar can develop. ABG shows acidosis, respiratory, but no pH. Okay. Peak airway pressure is 45. I don't remember actually the figure of the normal peak airway. Chest X-ray is normal. So with this, I'll go with the hysterectomy, B.
Absolutely, absolutely. What's happening here, you think? What's that called?
I think the chest expansion is the problem because
Yeah,
he's already intubated.
Yeah, what do you call that? It has a name, actually. If it happens in the abdomen, if it hasn't been in the abdomen, we have a name for it. And if it happens in the chest, what is it? It's not a trick.
Increased pressure? No.
Yeah, what happens in an increased pressure in the abdomen? What do you call it?
Compartmental syndrome.
Great, that's thoracic compartment syndrome, guys. Thoracic compartment syndrome. And it's a circumferential burn in the body, on the chest, and you need to release that, and you do escharotomy. Escharotomy. That's good, guys. It's really good. We have some more of that, and we need to arrange for some more part 2, 3, and 4, and all this. And we're happy to have any questions or comments, guys.
Thanks, boss, for this elegant lecture. Actually, it's very nice.
Thank you. We have a lot of these. Actually, we can probably easily make about 10 sessions out of just to finish the surgical critical care aspects, actually, and trauma. We can make it surgical critical care / trauma, actually.
Really helpful.
Thank you.
Making things simple and easy.
Yeah, thank you for your time, guys. As I say, that's the way we kind of teach here these days. We seldom actually give like a lecture. Mostly it's a oral scenario or as I said, multiple choice that we we go through this. It's more interactive things.
Thank you, Prof. It's very educational, and I think this is the way to go, and the guys can digest it better in this way, better than straightforward lecture, and the discussion is very rich. Hopefully, we can go with a series of these things.
Yeah, inshallah, Ma'moon, inshallah, definitely, I think we should make it a series, surgical critical care / trauma ICU, and we'll do it in parts, you know?
Yeah, that I think the way to go, and it is easy, digestible, and everyone is happy.
Absolutely, and the best benefit from this, guys, is if you go back now for each of these questions and read about the topic, read about hyperkalemia, read about burns of the chest wall and circumferential burn of the trunk, read about sodium abnormality, antidiuretic hormone, you know, secretions and abnormality. Read about this. Read about acid-base disorder. So if I remember, these are the topics. You see how many topics we went through today. You have Cameron, for instance, current surgical therapy that we use here a lot. The biggest book that we use here, guys, for our trainees and surgical residents, and Ma'moona, I'm sure in his time in Florida, would probably, I'm sure he would know that Cameron here is a big source. Cameron, Schwartz, Sabiston, Greenfield, not because of the American system that will biased or anything like this, but it's just they kind of really clear about what's needed. Cameron is a perfect source for many things, guys. So I'm sure you're gonna find a dedicated chapter. And the good things about Cameron is the chapters are short, so you can finish them quickly, right? So, and they're practical. They don't have much of a dry basic sciences. They're more practical about how to manage things. I'm sure you're gonna find, because I was talking to our surgical trainees about these topics maybe yesterday or the day before actually. There's electrolyte and acid-base chapter. I'm sure there's a chapter about burns in Cameron that's really good. So the really good things, guys. Traumatic brain injury, of course, and all that. So, all right, so happy to have you guys, and inshallah we'll plan to make this a series, inshallah.
Okay, I think as a reference, ICU book is Paul Marino. Is some sort of can be helped, but it's a little bit like more talk about it. But most of the guys go with it. Yeah, ICU book.
I have it next to me, Ma'moon. You know that?
Yeah.
This book, guys. This book really will change your how you deal. It will change the way you're a doctor. To be honest with you, there is stuff in this book that you are not going to find in any other place. It speaks simple, speaks to your mind, and it gives you very, very good, you know, guidance. Really important. You cannot be dealing with the critically ill surgical patients without reading this book. Thank you, Ma'moon, for saying that. Yeah.